Hello everyone and welcome to Book My Therapy. Today we have on board Gargi Sharma. She has completed her MBBS and post-graduation in psychiatry. Currently she is living in Canada, international medical graduate doctor. Hi Gargi, welcome to Book My Therapy.
Hi Neha, how are you doing?
I'm good, thanks for asking. How are you?
I'm also doing well.
Thank you for making the time to join me.
No, thank you so much for inviting me for this important and really rejuvenating interaction, I must say.
Look forward to it.
Yeah, sure.
Um, so when it comes to psychiatry,
Mm-hmm.
do you mind introducing what the work environment is for people back in India? And
Oh,
what are your daily tasks and how do you go about your daily work?
okay. So psychiatry, as you know, that this is also a medical degree, and we deal with the illnesses of mind, and also with that, it's like a cumulative thing that we go about in this. We have our subspecialties. We have adult psychiatry, which is a general psychiatry, in which we deal with illnesses, mental disorders, or issues that people go through in both male and female gender. Along with that, we also deal with child and adolescent psychiatry and geriatric, like mental illnesses, which are generally seen in the old age people. And along with that, we also deal with neurological disorders like Alzheimer's, dementias, and epilepsies as well. Yeah, these are the things that we go about. These are the specialties that we work under. And apart from that, what we do is we have the patient comes to us. Either they come on their own or they are brought by people, because we have many illnesses in which people do not know that they are ill, right? So we have this a segregated word that we have to interview the patient, and we interview the guardian as well who have come with the patient, and we corroborate the stories and whatever is going on, corroborate the symptoms and the history that we are getting from the patient and the guardian. And based on that, and apart from that, we do our own medical examination, that is the mental status examination, which we through which we get to know what the patient is facing at that moment objectively from our side. Then we make a diagnosis and we start the treatment, whether the patient has to be counseled or it could be we decide the severity of the illness, and then we start the treatment. If it's mild, we generally do just minor counseling, and we generally send the patient to a psychologist for therapy, because at times just talking and certain coping mechanisms that can be changed can be really helpful for the person, rather than just starting the medication. If we feel like that the just therapy is not going to work, and it's at a level that even for therapy the patient needs some kind of stability in the mental health, then we start the medications as well. It depends on a case to case basis. It's not like it's written in the books that this starts and then you have to start the medication. It depends what is the requirement of the patient, what is the requirement of the family, and how best we can help them. And I think it's the same everywhere, kind of. It's just that how many patients are aware of mental health disorders is something that is different. Like what I've observed here is in Canada, people are aware when they are not feeling mentally well. But in India, people just push through it because there's a stigma related to mental health issues. Like they really, if one says that, oh, I have gone to a psychiatrist, they are literally labeled mad at that very moment, not knowing that there's so many things that a person goes through, and the mind is one of the one. It's a mystery for us humans as well, because it's what the thought process are not we cannot dissect that. We can find our structural issues that can be going on, because we have developed scientifically that much. The technologies have improved so much, but still we cannot dissect what the thought process is. So for that, I think people really need to let go of the stigma that mental illness is a weakness. I don't think people hide when they are having a stomach ache. We shout about it. Oh, I have a stomach ache. But I think people should be aware that and should be empathetic and sympathetic towards people who are suffering from mental illnesses as well. Yeah.
Well said. So, I can only imagine what kind of stressors that you as a doctor would like go through in one day while dealing with others. So,
Yeah.
how do you deal with the daily stress related to your work and balance your life? And what are certain tips and tricks that you would intend to give to aspiring psychiatrists?
Yeah. So this is a really, really important question because I'm also a human, right? And psychiatrists are human. And if we see at the stats of, stress, psychiatrists are on the top almost. But it depends that how much, like there is one thing that is going on very recently in the TikTok world and the social media, setting boundaries. So what I have been learning, it's still a learning process for me because I have recently become a psychiatrist. So I've been working just for 3 to 4 years. Initially it was very difficult for me to just separate from myself from the psyche of my patient. And I had like 10 to 12 patients who were admitted under me because I was responsible for them. Obviously my seniors were looking after everything else, but I was primarily responsible for my patients, what is going on with them, and talking to them, and doing their mental status examination and getting to know their thought process and going through their life history. We tend to find out a lot of sad stories that come up with the patient's histories. And because we need to empathize, we put ourselves completely in their shoes, and that tends to affect us emotionally, and it does drain you out. So gradually what I have learned is whatever I'm feeling through them, it's just what they are feeling. They're communicating their emotions to me. So if I'm feeling that way while talking to them, maybe that's what they are feeling. So it helps me better in understanding my patient, in connecting better with them. But at the end, I know that it's their emotions, not mine. And it's their story, not mine. I'm just there as an accessory to help them get through it, but I can't do entirely everything for them. So you have to understand that kind of, we are not gods. We can't read everything that is going, and people need to get out of the mentality that psychiatrists can or shrinks can read your mind. We don't. Actually, you are just telling us what we want to know and what we need to know. And you answer your questions on your own. We just ask the right questions to you. So I think, and the aspiring psychiatrists have to understand that it can be a difficult field because we do not have a range. We do not have exact, blood work that will just tell us, okay, this person is having this thought and you treat it with this. It's our judgment. It's very subjective. It can be different from psychiatrist to psychiatrist. But in the end, we have to have that kind of, empathetic nature within a set boundary that can help the other people. And it's more like understanding ourselves much better. So if you are interested in knowing yourself better, I think you should go into psychiatry.
Nice. Um, you mentioned that you're an international medical graduate,
Yes.
so which means you have studied medicine and psychiatry in India and are looking for opportunities in Canada.
Yes.
So what is the process like, and what can you give a message to people to learn from your journey who are watching this video?
Okay. So yeah, I must say being an IMG is a very tough task because it's like you have done so much in your home country and you kind of start from the scratch, and it kinds of sometimes hits the ego. It does hit your ego. So, well, to come to Canada, there are certain hurdles that you have to cross through. And I think there are many sites that have been helping you out. helping IMGs, and there is many information on the sites, but the emotional turmoil that you go through and the reality of it is something that is not mentioned there. So you have to give your examinations again. Like I had to study all the subjects again because I was just studying psychiatry, right? So getting back into all the subjects, it was kind of difficult, but I had to do it while working. So that was one thing. So preparing for MCCQE part 1, they have at least scrapped MCCQE part 2, so that, and MCCE, that is the Medical Council of Canada examination. So I have done the part 1, and then you have to do NAC OSCE if you want to continue, if you want to do a residency in psychiatry or any kind of field that you have in Canada. Or you can take another route, that is the fellowship route, which I have been told about, but I am not very academically, very sound, because I do not have much interest. I like dealing with people, not with the numbers much. So I want to go into the clinical field. So that's why I have been more inclined towards I would incline towards doing the residency again. But there are other options that IMGs can go for in other provinces, that are the practice study assessments that are available in 8 provinces in Canada. I think the people can just search for it. Apart from that, after coming to Canada, you have to have a permanent residence status to give the OSCE exam or to enter in the CAMS, in the matching system. Before that, they ask for references and your Canadian healthcare experience, which is something at times gets difficult for us to get, because there are many doctors in community who work in community, and many of them who are inclined towards like pediatricians or family medicine or orthopedic or anything that I don't know about orthopedic, sorry, but they still can work or shadow doctors in the community, and they can get the reference. But the issue or hurdle that as a psychiatrist I'm finding is I'm the shadowing, because psychiatry is such a confidential branch. The confidentiality is so strong that you can't just enter it and shadow a person and then you get out. It doesn't work that way, because you see the life of the people in the wards, and you see the life and you hear about the life of the patients, and the confidentiality, they have to maintain the confidentiality. It becomes difficult. And the seats, you shouldn't forget the number of seats that they have. Just 27 seats in the present iteration of CAMS. So it gets quite difficult when there are so many aspirants who want to get into the working arena, who want to enter the Canadian healthcare system, but are, at times either disappointed, disqualified, despite having that much of, passion for it. Because the people might not be, they might not see what you have, and you might not be able to provide what they want. So this kind of situation, I think, is something that is very difficult that I'm facing. But I must say, I just entered the country like 1.5, 2 months ago, so I shouldn't be cribbing about it much. Yeah.
Okay. I can only imagine the struggle, right? Studying everything right from scratch, and then after getting an experience back home and then doing it again. Yeah, I feel for you.
Thank you. I think many IMGs will feel for me and I will feel for them.
Yeah. So, speaking of which, I noticed while in one of our conversations, you were mentioning about a couple of things like adjustment disorder and depression.
Yes.
Since depression is a term which is loosely used, um, can you help shed light on what is depression, what is adjustment disorder, and how to recognize the difference between
So,
them?
okay, that is a really good question that you have picked up. So, what is depression? Depression is, so these all are related to mood and our activities and how they are affecting our daily lives, right? how our mood is affecting the daily life, and how it is, becoming a hurdle for us at times. So what depression is, it's more it's a syndrome that we say. It has multiple symptoms, and it has a particular timeline that you have. And it's not just, feeling sad. It's like for consistently 2 weeks at least, you have to feel so low, and the mood should be low. And apart from that, you should also lose interest. You would not feel pleasure in the things you used to do. Like if I enjoyed eating a lot, like I enjoy ramen, right? I absolutely enjoy it. But during the period of depression, when you want to diagnose it as depression, at that time I would not appreciate that as well. Even that will not give me even the happiness that I used to get from it. So, and just, it's not just that, it's about feeling, there are certain feelings of like worthlessness, feelings of hopelessness, and loss of interest in the hobbies. You feel so lethargic, so tired all the time, and even talking to people, it feels like a task. Even though you might observe in many people around you that they are very energetic, and suddenly you feel like, oh, I haven't heard from that person for quite a long time. What happened? And when you call them up, it's like that person is not that chirpy as you expected them to be, as they usually are, right? And it's more of there is difficulty in concentrating as well in your daily task. You keep forgetting, and people are like, we get forgetful, I'm so forgetful. They get scared because of it. And they need to understand it's not just because there is some issue with the mind. It's because you are not able to concentrate, that it's not going into your head. It's not that your brain is just doing some wuzu that you are forgetting. It's because you're not able to concentrate enough, that it's not going into your memory. Okay. And apart from that, sleeping, you might sleep very less. Your sleep schedule gets disturbed. It's so distorted that either you will be sleeping less or you will be sleeping a lot. It's not just one that sleeping less is the diagnosis for, is the criteria for depression. It's if you sleep a lot as well. And there are appetite changes as well. You might eat less, or you might start eating more. It's like people do call it stress eating, right?
Yeah.
You just keep eating, you keep on munching, and suddenly you're like, oh my God, what have I been doing? That occurs. And apart from that, there are many somatic symptoms that, as we say, that we have body aches, headaches. So the entire body gets involved in depression. It's not just the mood, it's the entire body. And so, and this is something that, and it has a range. It has like at least 2 weeks of constant feeling this is depression. However, as you mentioned, adjustment disorder, that adjustment issues, it's more like an emotional or behavioral symptoms within 3 months. And there's one trick in this. There always has to be an external stressor or a life change that has happened. And symptoms, what happens is, and there is marked distress to the change, then which is very out of proportion to the actual situation. Like if we have someone who loved one passes away, the grief and the emotions that we feel, that is normal. That is not adjustment disorder. Okay, you have to get that. But if there is some kind of change, like situations like immigration at present, you can say, like people changing their country, that's a significant life change that has happened, and it is an external stressor that is occurring, right? And people are unable to, they are very anxious about thinking how I'm going to do in the future. They seem low, they feel hopeless. Oh my God, how am I going to continue in this country, or what am I going to do? I'm totally alone. I left my people behind. Will I be able to do it? Doubting yourself. And if you're working in an environment, you start acting up in that environment. You get either very irritable or very, very, you might cry over there or something like that. And you are always worrying, jittery, and, nervous. But there are no symptoms regarding there is no lethargy, and you do not lose pleasure in things that you enjoy. Those things do still bring pleasure to you. Okay. And it's not just for 2 weeks. It's like it's an ongoing process for 3 months at least. And there always has to be an external stressor or external situation or life change that is triggering these symptoms. Because depression is not bound to just external stressor. It can be genetic. It can be because of biological issues. It could be because of a stressor. It's not just bound to a stressor. That's the main difference between adjustment disorder and depression.
Perfect. Thank you for explaining this in simple terms. It's, it may sound similar, but it's so different, right?
Yeah, because it's more like what triggers it. It, like people say in depression, ki bhai, everything is going well, why are you depressed? Right?
Yeah.
That's depression. Person can be depressed if everything is going all right, despite everything is going all right. But in adjustment disorder, you can clearly see that there are changes that have occurred to which the person is reacting to in such a way. But the reaction might be exaggerated, and it might feel too much for other person because maybe they are not feeling it that way. They might be going through the same stressor, but they are not reacting to it in the same way the other person who is unable to adjust to the situation is reacting.
So when it comes to managing adjustment disorder and depression, so what's your take on it?
So in management part, as I said, depression, it can be genetic, biological, and there's no reason. The stressor doesn't have to be the only reason over there. So even in depression, if you remove the stressor or you learn to cope with the stressor, that is one way. So we in depression we do a combination of therapy, the psychotherapy or any kind of psychological therapy, along with medications. Right? We do use antidepressants to improve the acceptability for the therapy as well, because you feel so lethargic that you are not unable to do the therapy as well. You have, because in therapy there are certain tasks that are given to you that you have to do daily. It's a daily thing. It's like every day you get up, you have to do the task. It's not just one time thing that in therapy you did it, you're not continuing it in your life. Because what therapy is teaching you is how to cope with the situation, right? Or what changes in the mindset that you have to make. And for that, your brain, your mind, you have to be physically and mentally a bit receptive to those changes, right? So these are the treatment modalities that we go for in depression. However, in adjustment disorder, it can resolve on its own as a person starts adjusting to the situation, right? And other things that we can do is therapy. Like what therapy does is it's majorly what we are not able to think, the other person is helping us to think it out loud. And what changes we are not able to understand to bring in our life, they are able to, and they're equipped to know how we can bring those changes in our life. And it rarely, or very, it does not require medications much. It's just because it's an external situation that is creating the problem. It's not an internal stuff. If there is some kind of sleep issue, you can like improve the sleep hygiene, and you can take medication for some time, but not long duration, because even those can be harmful for the body later on if it's not regulated, right? However, this adjustment disorder can be treated well, and it's not a recurrent stuff. And because once as we age, we get used to the setbacks that we get, because initially what I've seen in people over here, they come at a mere age of 18, and at that time we haven't handled too many stresses in our life. Our parents have been doing that for us, specifically in India. I wouldn't say that it's generalized, because many people, they have other issues in their family even before 18. But yeah, we are not equipped as much to handle the changes as we are when we grow older, right? But that's not the case for depression. It's like every time it might hit as hard as previously, but you might come out in a better way. The treatment is there. And
So you mentioned about, one of the ways of treating depression is taking medicines, which is antidepressants, right? So is there a time frame, say for example, a person is depressed and a doctor prescribes antidepressants, so do they need to take it for 6 months, 1 year? And also I have noticed that there is a certain level of stigma associated with it, where people,
yeah,
they say that I don't want to depend on one pill because that pill is not going to decide my emotions and whatnot. There is also a misconception, or I don't know if that's true or not, that if, for example, say a person is taking like 50 grams of antidepressants, then their body would be used to taking 50 grams over a certain period, and then for them to feel normal, you'll have to increase the dosage. Like how true is that?
okay, so this is a very tricky situation. Again, it depends on person to person, but yeah, the duration, what we call it, the 6 months and 1 year, what we call it, because depression lasts for 1 year at least. If you see a normal course of an illness, like for viral illnesses, we say that it's for 7 to 14 days, right? At least that is the duration that the viral illness will go for without treatment.
Yeah.
Same for depression, that if you do not treat depression, it will go for at least 1 year without any treatment. So that's why the medication is like, initially we just we start with the lowest dose. With it's not decided that only one medication can be started. It depends on the other situation, physical parameters of the other parameters of the patient, that we decide an antidepressant or any kind of a medication for the patient. And that we take it up to a level that we see there are certain improvement in the symptoms. And the 6 months that you mentioned, like after the person starts feeling better, we continue the same doses for 6 months, which is the maintenance period. We maintain at the same dose so the person can maintain that level. After 6 months, if we see that the patient is doing quite well significantly, and they themselves observe the changes, we start decreasing the doses mildly and see whether there any kind of symptom is reoccurring. If we see any symptom is coming back, we take it back to the same doses that they were on in 6 months. It depends. If they are not seeing the improvement, we increase the doses again. It's tailor-made for the patient. It's not for everyone. Many patients just respond to the lowest dose as well. We continue the same dose. We do not have to increase it all the time. It's what is set for the patient, where we do not see any kind of side effects, and we see significant improvement in the patient. Because what you see in depression, you do not just feel low, you lose a significant amount of time of your life, right? Because it affects your normal living, it affects your relationship as well, it affects your physical health as well. So I think it's more like let's say for diabetes. This is an example I used to say to my patients, that when you're taking the medication for diabetes, it's not that you are dependent on it, right? Still you regularly take. It's because it's regulating a system that your body is unable to regulate on its own. It's taking the assistance. So antidepressants, I would say, it's just like a crutch while you have broken your leg. It's just a support. You're still taking the steps on your own. The crutch is not taking the step for you, right? You are the one who's lifting this crutch, and you are the one who's putting the foot forward. It's not the crutch that is taking. It's just supporting you so that you do not fall. That's what antidepressants do. So I think people, yeah, it's just a support. It's not going to make your emotions. You are not going to feel happy just because you're taking the medication. It's just removing the hurdle that was making you unable to feel happy. You are not going to it's not like the kind of happy pill that even if there's a sad situation, you are going to remain happy. No, you will respond to the situation like you normally would have. It's just that it removes the barrier or the hurdle of feeling those emotions or handling those emotions in a in a way that is helpful for you, which is safe for you. Yeah.
Well said. And so you mentioned about, depression where people experience loss of joy when they used to normally enjoy doing things,
Mm-hmm.
and there is a disturbed pattern in their sleep and eating as well.
Mm-hmm.
And then about, everything can be going perfectly well in their lives to the other person, but then internally they could be depressed. So is the opposite also true? Like a seemingly normal person who is, doing the daily task, daily lives, and can they also be depressed?
Yes. Again, it's like it could be the level of depression. Like as I said, the severity is different. It could be just that they are unable to feel happy about situations, but they are just going through, they are just pushing through. Like you just push through because you know there are certain things you need to do. At that level, you are still able to function properly. So that's the severity. It's just the severity. It does not say that you are not depressed. You might have mild depression symptoms. But when you are like unable, the functionality of the person is deranged because of the illness, then we go that it's okay, it's moderate now, it's severe now. So it's the spectrum of the severity of the illness that I would say. Otherwise, people these days people are using the term high functioning depression as well,
Yes.
right? But it doesn't mean that a person is not. It's something that how the person is dealing with those emotions. Like internally, there might be many thoughts like going on, but outwardly they are very good because it has been going for so long, and outwardly they are able to make a persona, a
Hmm.
facade. They are
Hmm.
able to present that facade so well that you are not able to recognize it.
Hmm. Wow. So that brings to the end of the podcast. Is there anything else that I should have asked?
uh, I guess this much was good enough. And I would just say to like what I am going through now, many people have gone through. So it's getting to know people who have gone through the same situation. It's like very helpful because I had the pleasure of meeting so many IMGs over here in Canada who have gone through the process, who are dealing with their situation and who have helped me deal with the situation. So I would say that if you know people who are going through the similar situation around you, talk to them. They will help you out because we have that nature. We are empathetic and sympathetic. Okay.
Nice. Thank you for making the time, Gargi. It was a nice talk. It was a pleasure talking to you.
Pleasure talking to you as well, Neha.
If you like this episode, please hit the like and subscribe button. Thank you. Bye.